one must, as one is in developing countries, you can imagine they wouldn't have PET, for instance, some of the many people in countries. So Gylam 67, such people can try and look at Gylam 67. That's why I must really qualify it first, that they can do their pneumocystis carinii or pneumocystis jirovecii to clearly see what is happening. They can do their cytomegalovirus outline, and there's nice criteria of showing them what is there. They can distinguish Kaposi sarcoma again from the other infections with their Gylam 67. A whole lot of things can still be done with Gylam 67 for those HIV, and they can see again the pattern of tuberculosis, because then you will see your nodules there versus the non-tuberculosis one. The non-tuberculosis with the pneumocystis will be diffuse, and so there's nice guidelines for such work to be seen with the Gylam 67. However, again, if you can afford it and if the patients are there, but not in all the cases, I must say probably you have to go to the for complicated cases, you may want to bring something like, again, PET. Wherein why we should bring PET, we can with PET try to understand how the HIV is really causing the pathology, because with that we have seen with our group you can use this modality PET to try and see, and therefore extrapolate and have areas where you can get good level tissues for biopsy and study the cells and see then what is it that we are seeing, what is happening in those things, and start to look at is there apoptosis happening, and therefore account for the uptake that we are seeing. If it is the case, then we can start thinking thinking laterally to see, shouldn't we try anti-apoptotic tracers or anti-apoptotic drugs to stop the manifestations of HIV, and you can look at it and understand what is it that you need to intervene at, stop the home of the CD4 into the lymph nodes. If you stop the homing, can that be the way to address it? Because then if you are seeing the explanation of the uptake that we are seeing at DGPET, it could be due to the lymph nodes are homing, that then you could try and then work together with colleagues in pharmacology in a multidisciplinary fashion to try and see maybe that can be the way. So FDG work, it's really not only showing you what is happening, it's a way of seeing what is the status of the patient, extra plasmic way, without looking at the blood.
Right,
because
so
sometimes
you look at the chemistry of the particular thing, and it's a complex factor. I mean, in terms of that.
Exactly, and remember some of the other things of looking at the bloods only, they don't necessarily correlate sometimes always with the clinical status. You may get your CD4 out of line with what the patient is, or they may lag behind even if the patient have been treated. So you may need something to understand why is this patient doing so bad even if the bloods are like this, and therefore FDG work will be there to help you there. Other things is that now that the medication it's readily available, but the medication is not without side effects. You can also study the side effects of the HIV drugs by looking at FDG work and things like lipodystrophy, which is important as well. Then you may see that, and you may as well have tissues taken in areas that are metabolically active, and you may have an objective way of studying whether there is response to stopping and when to stop, and so on the medication. That may also have future manifestations in how we have to look at the coronary manifestations for that as well. And taking it out again to the tuberculosis.
Yeah, well, I mean, coronary manifestations, there's been good studies showing FDG with inflammation in the coronary arteries.
Yes, and that is something else that we really need to start looking at it, and it will work nicely there in that regard. Especially if we are going to do it in a multi-center way and then validating with the various sides, rather than maybe one side looking at it and so on. And as we know, HIV is the dual case with tuberculosis. Obviously, there will be lots of patients with HIV that are co-infected, and TB is actually the biggest killer with HIV patients. So we really have to zoom in TB and really fight the TB battle. Then many of the patients may not die, but TB is in fact really a big killer. So really understanding tuberculosis and advising colleagues there, it's of paramount importance. And often, currently now we have really shown, because there isn't quite a good standard in showing extrapulmonary tuberculosis.
Right.
And you know, where do you go? Where do you image? But with FDG, of course, injecting, and you can then see the whole
body.
You know,
it could be anywhere. I mean, TB can be anywhere.
And really, then that's where we really are much more superior than the other people, really. Because, I mean, we have seen that clearly we'll see much more nodal manifestation than with conventional imaging, including things like CT and so on. So you will see much more better extrapulmonary manifestations with FDG work. And not only
particularly when you've got those very low CD4 levels. So.
Yes, without any doubt. And not only that, then you can also have a way in which we are trying to say, when you see that, how do you know that this patient is going to have resistance or respond to TB? As I said, TB is a killer, so you need to know whether you're going to change your medication into the other type, because you don't need your MDR, your multi-drug resistant TB to go on. So monitoring and predicting response, it's of importance. So we're able to say, look, if this person has got more than 5 lymph node basins involved, so he is likely to be a candidate for your poor response. So you got to know that as a clinician, then you will then have to start watching the patient closely and bringing him so that you can then change your medication or extend the treatment. So that will really influence and change the way TB is managed from such a thing that is considered expensive, such as FDG. And not only can you do it when the patient is coming, obviously FDG PET is expensive, we realize it. Now what we have done is to try and look at it in the middle of the treatment, wherein the patient is coming, and then in the middle, then we say, this patient has been treating, I don't know whether I'm winning or losing, then you can bring him there. And similarly, you can have the criteria into predicting whether this person is really going to respond or not.
Because a lot of the treatments for resistant TB are quite toxic and expensive, so you need to be able to use them at the right point and decide this patient will go that way and this patient wouldn't. So it's very useful.
It is useful, and really looking at it, I mean, the explanation that TB does take up much more FDG than other infections, it's fascinating in itself. It tells us that you can't only be looking at the macrophages, as I was explaining earlier. There could be something that the bacterium in itself, if you look at the structure of the tuberculosis, could have something to do with the uptake that is retained when you do the retention, early and late imaging of FDG.
Right.
And that in itself, if you now are going to take a full key of tuberculosis and study, looking at things like mycolic acids and so on, based on that, you could come up with something that would then, that's where we're speaking about molecular imaging. You could start thinking about other ways of coming with intervention in tuberculosis.
Right, for example, radioisotope therapy for TB or for HIV, which has been proposed on other podcasts.
Or when they propose newer drugs, they might know how to actually do those drugs, because based on that you can try and link the two, and that is important work, So PET has got a very good potential in tuberculosis, not only for the FDG work, but for future development of drugs. And also remember, currently we are treating TB normally for 6 months, but that actually is more of a thumbs up. In fact, we really need to be sure, but is it 4 months? Who knows? Actually, in an uncomplicated tuberculosis, it is possible that you only need 4 months or 3 months,
right.
And you need a very, an objective way of assessing that. And FDG can come in handy.
And some patients you need to go longer, so you need to be able. So it's an objective way to do that, and some of these drugs are expensive, so it may actually be a cost-effective way of doing it as well.
Precisely.
Okay. So one thing I didn't touch on though is, we're quite fussy with FDG in oncology about what the glucose levels are.
Yes.
How does this apply in infection imaging?
Well, currently what we have seen, it doesn't seem to be bothering with infection, whether the patient has got elevated blood sugar levels, because we have seen a number of patients where we haven't given insulin at all. We have imaged them and it doesn't change the intensity of the FDG and the uptake. Not at all. The only thing perhaps one might argue that if the same patient is to come again and you have to use SUVs, you have to bear in mind that if the blood level levels are going, the blood sugar levels are different.
Right, it may affect the
yes,
LCC.
but otherwise, in terms of whether you are going to have less uptake or a false negative, that doesn't seem to be the situation in that situation. And again, that may be explained by the mechanisms that are there. In that, not necessarily depending on the insulin levels that is supposed to give you the uptake into those cells. The granulocytes will forever want to utilize the sugar because for their energy they really need sugar, and therefore that uptake will be there. And same with the macrophages. So the pattern of time could be an explanation for that, but clearly that such patients, when they come for routine basis, one does not need to tell them that we really go ahead and image them. That can be again verified independently at other sites and exams.
Well, that's a very useful thing that you can do that. So FTG, in general, is a very useful tracer in many ways that we really hadn't been using it previously. Is it funded at all in South Africa?
Well, the FTG work, we have routine work for oncology like many other places, but we do have, because of the problem there, we do have funding for doing research in tuberculosis, HIV and other infections, and one must be thankful to Nuclear Technology Product, which is a subsidiary of Nuclear Energy Corporation of South Africa. It's actually sort of your insto when you look at Australia, and that is a government, a parastatal meaning that it's semi-private, but it is wholly owned by the government. And
right.
So the government realizes that and hence that we fund such a.
Very useful, and of course that means that we get a chance to see you here and get to talk about that. So I really appreciate your time. I've taken up a lot of your time, I know, but I've found you've removed a lot of confusion from my mind, and lots of others who've who've always found infection imaging a confusion of nuclear medicine and PET. So thank you very much appreciated, and thanks for coming down to Australia.
No, thanks, really once more. Thanks for the opportunity. I think it's both ways. The Australian colleagues, yourself, have been listening. I hope done the same, but of importance, I'm looking for collaborations of how do we really take our problems together forward.
Yeah, excellent. Thank you.